In CLL, we have many treatment options now in frontline therapy. We still have for the fit patients the FCR regimen as a standard regimen, which has the concerning disadvantage of late toxicities such as secondary acute myeloid leukemia. Hence, we can consider how we can improve this regimen or make it even less toxic. Attempts to improve this even further are, for example, maintenance treatment strategies, as we test right now in the CLM1 study. The results were also submitted to the ASH meeting, and they will show here if the remission duration can really be prolonged by the administration of Lenalidomide. Then we have in the co-morbid patients several options combining less toxic chemotherapy as Chlorambucil or Bendamustine with antibodies, with the 3 CD20 antibodies being approved in CLL right now, Rituximab, Ofatumumab or Obinutuzumab. This is all in contrast to the novel agents. Then spring this year, Ibrutinib monotherapy is approved in frontline therapy of CLL. However, we have to consider that the study with which Ibrutinib was approved was done in elderly patients above the age of 65 years and in comparison to Chlorambucil. If you look at the progression-free and overall survival curve, I think it's doubtful that this will also be better than some of the chemoimmunotherapy regimens, but still this has not been tested, for example, in comparison to FCR. So when we start now frontline therapy in a patient, we have to balance between either administering chemoimmunotherapy or Ibrutinib therapy. Ibrutinib maybe being more efficacious than several chemoimmunotherapies, but having the disadvantage of an ongoing treatment. We don't know much about late toxicities. We don't know much about cumulative toxicity. So the regimen is well tolerated in comparison to chemoimmunotherapy. And then we have patients with 17p deletion who are already for 2 years, if available, treated in frontline with Ibrutinib or also Idelalisib. But we see now also that this is not enough for this patient group, and therefore we need new studies, in particular to treat these very high-risk CLL.